Hello, good afternoon. I hope you can all hear me.
I can hear you well, Maria.
Great, thank you. So, good afternoon. I'm Dr. Mercadal, and with Dr. Marumbo, first of all, we would like to say thank you to Espegan for all the help coordinating and to be able to do this second webinar of the Portal Hypertension Special Interest Group. First one was last year, and actually one of the main questions at the end of that first webinar were related to pharmacological treatment in portal hypertension. So that was a bit the idea of doing this second one and cover all the issues around it. So the idea is to talk about a bit of what we know up until now about this in the beginning, and then through different clinical scenarios we can discuss what we usually do at our hospitals and what obviously you do too. So if you have any questions, please just use the chat group and we'll be very happy to answer them once I finish my more theoretical part, and then obviously while we are reviewing the different clinical scenarios. So for the purpose of this webinar, we are basically going to review non-selective beta blockers and somatostatin and analogs treatment. There has been other pharmacological treatment studies in patients with portal hypertension, basically in adults, antioxidants, statins, antifibrotic agents. But for the purpose of this webinar, we are going to basically talk about these two. So let me go back to the basics just for two slides. So the portal vein pressure basically is proportional to the splanchnic blood inflow and to the resistance opposing this flow. I don't know if you can see my arrow. Nayeli, you can see the arrow pointing?
No, I don't see the arrow, Maria.
Okay. Well, here in this image, you can see where the portal vein is, and basically what I said, no, the portal vein pressure is proportional to the splanchnic blood inflow and to the resistance obviously opposing this flow. You can actually measure this portal vein pressure, but we usually don't, through the gradient between the portal vein, the pressure in the portal vein, and the inferior vena cava that you also have in the picture. In healthy patients, you shouldn't have a really high gradient here. It should be more or less between 1 and 5 mg. So in all causes of portal hypertension, the increase of this resistance to the portal flow is initially the pathogenic mechanism, and it's followed by the increase in the portal venous inflow. So depending on, yes?
Apologies. I think they're saying that the slides are not changing. So you're still
Okay.
the first one.
Give me a second. No, they're not. Don't worry. Basically, what I'm trying to say is the increase of the site of increase of the resistance what we have is what is going to help us classify the different types of portal hypertension. Prehepatic, if the increase of resistance is prior to the portal vein, prior to the entry of the liver, or intrahepatic when it occurs within the liver, and posthepatic when it occurs when the blood exits the liver. And basically, in our patients, what we're going to see are by far the most frequent is going to be portal vein thrombosis, cardiomyopathy, or cirrhosis of all causes. It differs in adult patients because mainly all the studies done in adults are in patients with cirrhosis. So obviously, when we talk about all the studies done up until now, we do have to keep in mind that the majority of patients in adults are going to be with cirrhosis and not portal vein thrombosis. So one of the first consequences of this portal hypertension is that you or the patients develop portal systemic collaterals. So the development of the therapies to prevent or the therapies for portal hypertension were to prevent variceal hemorrhage because of the high incidence of this bleeding that actually associates a high mortality rate. Initially, treatment wasn't pharmacological. Initially, treatment was surgeries. But in adults, what they saw is that the risks associated with these surgeries, hepatic encephalopathy and overall mortality, were too high to keep on doing these, at least as primary prophylaxis. Secondary is another story. So with the knowledge of how portal hypertension was working, they started developing some pharmacological treatments to see if they could subsidize certain prior surgeries. So what they found is that non-selective beta blockers, the beneficial effects that they had in portal hypertension was the ability to decrease portal pressure through the reduction in portal and collateral blood flow. Basically, decreasing cardiac output through beta-1 blockade and splanchnic arterial vasoconstriction through beta-2 blockade. Adults, actually, the first studies that we find in adults using non-selective beta blockers are in 1981. This first study of Lebrec and colleagues give me a second. Are the slides still not moving?
Yes, they were not moving yet.
Okay. I'll try it again then. Are they working now?
I can see another slide, but I don't see them moving.
Okay.
Yes, but if you make it presentation mode, maybe.
Can you see it now? Because presentation mode is obviously not working.
Yeah, I can see
So
them moving now. Yes.
if this is good enough for you, I'll continue like this so we don't have to start again, basically. Is that okay with you?
Yes, I can see them moving. Yes.
Okay.
Thank you.
Sorry. So I was here talking about the first studies done in adults. They were, as I said, basically everything is done in patients with cirrhosis. First studies done with non-selective beta blockers go back to 1981, using propranolol for prevention of recurrent gastrointestinal bleeding in obviously patients with cirrhosis. And since then, you can see a huge number of studies on propranolol, on using propranolol as primary prophylaxis, as secondary prophylaxis, using it on its own or with endoscopies, and in cirrhosis that are actually compensated or decompensated. So let's run through a bit of what adults have done up until now. So propranolol, when used, usually you have a starting dose and you can increase it, and the goal is to find heart rates of 55-60 BPM if obviously the adult tolerates this. But it's obviously the first thing you're going to say is that this is terribly difficult in children. Do you do it at home? Do you do it at the outpatient clinic when they are crying? And it's difficult in general. And also it has quite a few adverse effects, at least in adults: fatigue, bradycardia, hypertension, constipation is quite an issue. So we evolved a bit and started looking into carvedilol. Carvedilol additionally exerts intrinsic anti-alpha-1 adrenergic activity and facilitates the release of nitric oxide, induces intrahepatic vasodilation, and further reduce portal pressure. So basically what we're saying, its decrease in AVPG is more pronounced than in propranolol and nadolol. And actually, it achieves this reduction with low doses. Carvedilol is also used, as you know, in arterial hypertension, and you can use lower doses in portal hypertension. And very importantly, at least for us, and we can discuss this later and see if everyone does it or not, it shouldn't require titration based on resting heart rate to see an improvement anyway. So in general, what adult studies have put together is that carvedilol is preferred to propranolol right now because of this greater reduction, because it's better tolerated, the administration is simpler, but also because it actually maybe, but yeah, there are already few studies preventing ascites and potential survival altogether advantages. This is basically the newest evidence in adults with portal hypertension using carvedilol. It lowers the incidence of any decompensating event, mainly ascites, in patients that have compensated cirrhosis and clinically significant portal hypertension. It also lowers the incidence of further decompensation if they've already had bleeding, and it improves the survival in patients with decompensated cirrhosis. We are now not talking only about patients with compensated, but decompensated cirrhosis that actually hemodynamically respond to the treatment. So the new approach basically is that try and look for patients that have clinically significant portal hypertension. Here in Garcia Sau's one of last articles, you can see that the new paradigm in compensated cirrhosis is through elastography and platelet count, screen for those patients that actually have clinically significant portal hypertension and start carvedilol to prevent the decompensation. And what do the last guidelines say about this? So here, this setting is compensated cirrhosis. You have a patient with mild portal hypertension. It's still not indicated to start carvedilol because it doesn't actually prevent the development of what we call clinically significant portal hypertension. If you actually have a patient with clinically significant portal hypertension, having varices or not, you should start carvedilol. We're talking about adults here. We can discuss children once we get there. Obviously, if the patient has high-risk gastroesophageal varices and they do not tolerate carvedilol as primary prophylaxis, you can also use ligation. But also the interesting thing is what I was saying before, in patients with decompensated cirrhosis, I'm not minding if the decompensation is because of bleeding or because of ascites or hepatic encephalopathy. The idea is to use carvedilol in variceal bleeding to prevent the rebleeding as secondary prophylaxis, obviously scoping too. And in the other patients that haven't bled but have had ascites or hepatic encephalopathy, also started to prevent the first bleeding or as primary or as secondary prophylaxis. And what about, because maybe the discussion up until now, when we're talking about esophageal viruses, is sort of easier. But what about gastric or ectopic viruses? Can we use carvedilol? Is it useful? In adults, basically, it's used as prevention of rebleeding and prevention of decompensation, or even after using adhesive glue injection. And in portal gastropathy, absolutely the same. So the thing is, up until now, we've talked about cirrhotic patients. We have in children a fair number of these type of patients, so maybe we're going to get some ideas from them. But obviously, a great number of our patients are going to be non-cirrhotic patients. So this is from the last Babeno meeting. Basically, it says that we do not have sufficient data on beta blockers or endoscopic therapy as primary prophylaxis. But basically, you should follow the guidelines for cirrhosis. Just a quick remember about contraindications of non-selective beta blockers. Basically, the majority of them are not very frequent in children when asthma it is. So just be careful and take it into account. So now that we know all the work that adults have done with their patients with portal hypertension, let's see if we can use any of their knowledge, or what have we done up until now. So we started fairly good. They started in 1981, and by 1985, we can already see a first study where it's first reported changes in splenic pulp pressure, which is not great measurement of portal hypertension, but it's a first step in trying. But it was the only pediatric analysis assessing this portal pressure changes because of propranolol therapy. More than 20 years later, in this review of primary prophylaxis in children, you can see that there aren't very many studies with beta blockers in children. You can see it marked here. There's only 3. Obviously, there were already others using EVL and so on, but not that much in propranolol if we compare it to adults. And if you actually screen now for everything that we've done with non-selective beta blockers, it's limited to primary and secondary prophylaxis of variceal bleeding. There are no formal randomized controlled trials evaluating either safety or efficacy of these in children. We don't even have appropriate dosing for beta blockers. And obviously, we don't know about targeting the change of heart rate that I'm sure many of you, even us at some point we did, or still do, target, the change of heart rate in our patients in the outpatient clinic or at the hospital. And this is fairly new for a few years ago. You can see that by 2016, still we had the first 3 studies that I've already mentioned, and then just one more mentioning actually using propranolol in pediatric patients. So it's very difficult to do any recommendation based on the pediatric data to use, or even to say if primary prophylaxis is useful or not, to prevent bleeding in our patients, when to start it. So I'm sorry to get to this point, but basically we don't know much about using carvedilol or propranolol in our patients. So what we wanted to do a bit is talk about what we actually do in our clinical practice. Are we using propranolol or not, or have we shifted to carvedilol? Do we actually think of pre-primary prophylaxis in patients with cirrhosis and clinically significant portal hypertension? Probably the first question is in children, what is clinically significant portal hypertension? Do we just know if we scope and have large varices or small, is that already clinically significant? So that's probably the first question to answer. Do we use it as, do we do primary prophylaxis? If we do we use beta blockers or do we scope? Secondary prophylaxis, sort of the same. Do we mix it? And do we actually use them, propranolol or carvedilol, in palliative settings? So we're going to talk a bit about our experience. Give me a second so Dr. Marumbo can start his part.
Hi, Maria, can you hear my voice? I'm not sure if my microphone's working. I'm having camera issues.
Yes, it works perfectly. Thank you.
Okay. I don't think my camera's working. I keep clicking it on, so you'll have to go without my face, unfortunately. Sorry. Okay. Can I be relinquish control of the presentation?
Or if not, I can continue. Don't worry.
Yeah, okay.
Do you want me to?
Yeah, advance,
Yeah.
if you mind, advance the slide, please.
Can you see it?
I can see it. Fantastic.
Oh, you're
Great. Great, thank you. So, so I work at Leeds Children's Hospital, which is one of the 3 liver centres in the UK. So we have a sort of a transplant burden of about 25 to 30 patients, and the prerequisite number of children with chronic liver disease who have portal hypertension. So, I guess the first disclaimer is that this is early days. We've only started using carvedilol in our practice this year. Prior to that, we'd give propranolol for severe cases of extrahepatic portovenous obstruction. So this would typically be children who have no option for a mesorex shunt, and we felt that a TIPS was not indicated for them, or if we're going for a transplant, would TIPS them anyway. So so we had a very narrow band of patients which used for propranolol. Given all the evidence that Maria has just presented, we had to decide, okay, we wanted, the benefits seemed for us the greatest to be in the children who are decompensated and who are listed for transplant. So we still haven't transitioned to using it for primary prophylaxis. We're a center that performs our own upper GI endoscopies. So we haven't quite got the bravery yet to put children on carvedilol only and not perform endoscopies. And we're certainly not using them in cases of extrahepatic portovenous obstruction. So really our narrow band ends up being children with chronic liver disease and primarily patients who are listed for transplant. Again, this will vary from your region, but at the moment in the UK, we have quite, waiting lists can vary from a couple of months to almost over a year. So we've seen increased morbidity while waiting on the transplant list for our patients. So this is the particular group that we've targeted for the use of carvedilol, especially in the smaller children. So, I'm talking about children with biliary atresia who are small, and we have concerns about performing sclerotherapy. There is the theoretical risk that if you perform sclerotherapy on a listed patient, there's a risk to the portal vein because of the agent going through the shunt into the portal vein and causing thrombosis. And then, of course, if you give sclerotherapy and then you then get an offer for a graft, say in 48 hours, and you give them high-dose steroids after transplant, that they might, suffer severe ulceration. So certainly we've welcomed carvedilol in this group of patients, starting them on it. So we feel that we can avoid a bleed and not have to perform sclerotherapy, would be very happy. And then there's the next group, which is essentially the teenagers, sort of undiagnosed Wilson's and autoimmunes, diagnosed very late, already have clinically significant portal hypertension on arrival. So this is another group of patients we've started using carvedilol in. I thought it might be most useful. So next slide, Maria, please. So I thought it would be useful just to simply run through what we do and run through 2 particular cases. I've gone for the smaller children with BA, which I think is the group of children, if they're waiting for transplant, might get the most benefit. This will be similar, I'm sure, in all your various pharmacies and departments. We've essentially split our dosage up to those who are starting this in an outpatient setting and those who are starting in an inpatient. With inpatients, we're a bit more cautious, the theory being that if they're already in hospital and they're that sick, we don't want to lose flow to the graft by sort of suddenly dilating them. So we start at a much lower dose and we build it up slowly, and then we sort of do weekly in the outpatient group. Next slide, please, Maria. So you'll see a reference in my cases to shear wave elastography and the HARI, the Hepatic Artery Resistance Index. Shear wave elastography is simply the non-invasive method for liver stiffness that we use in our center. I liken it to, I'm not a physician like the radiologists are by any means, but I liken it to if you drop a drop of water into a pond and you see the ripples that move in a perpendicular direction to where your point entered. So we're not using a pressure wave like FibroScan. We use an ultrasound wave, which moving forward, it has a speed of about 1,500 meters per second, but the shear waves which go perpendicularly come off at a much slower, and therefore you find a region of interest and you take about 10 measurements from that region of interest, essentially measuring the speed of the shear waves, and that gives us we sort of 2D reconstruction, and we get a unit of stiffness which is sort of expressed in Pascal. So that's what I'll be referencing in my cases. And resistance index, I'm sure you've all used. Normal ranges are from 0.5 to 0.7. Essentially, it's a Doppler investigation of the hepatic artery. The higher the number, the more resistance there is to flow into the liver, and that's another surrogate marker of sort of congestion or fibrosis. Next slide, please, Maria. So the first case, typical, we won't dwell on this too much, a baby born at term, decent weight, antenatally picked up a cystic structure within the abdomen, postnatally had a abnormal gallbladder with an abnormal wall, no common duct identified, a cyst present, a triangular cord, and a dominant hepatic artery. So this is a child that underwent an intraoperative cholangiogram fairly quickly and a full Kasai portal enterostomy at 11 days of age. Next slide, please. So I've put the follow-up blood results in the table just to illustrate his progress. As you can see, this is a child that didn't clear their jaundice. And at around 6 months of age, when it became apparent that they weren't going to clear their jaundice, we enlisted them for transplantation. The child seems to be getting on okay, and hit a step when they developed, the nutrition began to suffer, required heavy supplements via sort of nasogastric feeding, etc., but then developed frank ascites and had an episode of suspected cholangitis, which is where you can see the bilirubin rose up to about 401. At that stage, the child, the baby was an inpatient on the hospital ward, and we even had to start parenteral nutrition because we could not get this child to gain weight. If you move to the next slide, please, Maria, so I can run through the scans. Thank you. So you can see there at 6 months at the time of listing, the scan was fairly benign. The portal vein was patent. Spleen wasn't terribly big, but not terribly big. Resistance index was normal. I haven't included them on there, but his shear wave elastography measurements were about 13. Sorry, not about 11. And in our center, we use measurements of up to 10 kilopascals as normal. So just slightly above normal, but not so much. The point at which at 11 months when the child sprang some ascites, you can see the resistance index had increased. And shortly thereafter is when the child really deteriorated and ended up on the hospital ward. That's when we needed increasing doses of diuretics to manage the ascites. The elastography, the liver elastography had doubled. And we were really at this stage thinking, well, this child's going to get, at any minute now, this child could sort of get a bleed, etc. And that's the point that we started carvedilol on. And, maybe this is a false dawn. Maybe this is something that might not be reproducible as we start using more, getting more experience at using more patients. But it was quite encouraging to see that the resistance index had dropped from 0.9 to 0.8, and the liver elastography measurements had come down. So if in a baby like this, it appears to have bought us more time. The child is now about 16 months. We're currently working up an altruistic liver transplant because the child's been waiting for over 8 months now. The platelets have continued to plummet, and the child clinically, the portal hypertension, the ascites is under control. But this is a case in which traditionally, well, it's hard to say because it hasn't happened, but we would expect that the child might have had a bleed and may have, whose ascites may have gotten worse. So this is one we feel that the carvedilol has bought us some time, and this is the kind of patient we're looking to use it more in. Next slide, please, Maria. Second case, so it's again biliary atresia, but slightly different aspect. This is a child that had hypothyroidism, and there was a delay in the child getting to our center because he was being treated for his hypothyroidism, and the endocrinologist felt that the high jaundice levels were consistent with the diagnosis of hypothyroidism, but eventually the child made it to us, had all the signs on ultrasound for biliary atresia, underwent a Kasai at 47 days of age. Next slide. So this child was slightly different in that by the time that he hit 5 months of age, he'd had 2 episodes of clinically confirmed cholangitis. And his first ultrasound scan showed very elevated liver elastography, so 50, which may have been secondary to the cholangitis he just had. His Harry was elevated, but he already had clinically significant portal hypertension. His platelets had been plummeting, and he had signs of early varicose formation already. He trundled on for a bit longer, seemingly okay, but by the time he had biliary lakes, so these cystic areas within his liver, which put him at risk for more episodes of cholangitis. And you can see, despite his elastography measurements reducing back down again, his resistance index was creeping up slightly. His spleen had gotten much bigger, and if you look at the table below, his platelet count had plummeted very rapidly. And then, sure enough, shortly afterwards, he got clinical ascites and had been started on oral diuretics. So he's a child where his synthetic function had remained fairly preserved, but with frank ascites, sort of his baseline, he'd gained almost a kilo in fluid in a short space of time, and sort of clinically evident portal hypertension on bloods and on his elastography measurements, and was waiting for a transplant. So this is a child in which we weren't concerned about synthetic function or his bilirubin levels, but he was on double diuretics, and we were thinking he's going to be waiting for a long time. So we started carvedilol after he'd had another infective episode, and whether this is replicated or experienced by other clinicians, but what we found with him is that his ascites has become much easier to control. So he's dropped right back down to 11 kilos, and his tummy is very soft, not completely flat, of course, but his tummy has come right down and is much more soft and manageable. So he's one he's currently waiting for, his mum is being worked up for an live donor transplant. So this is one where with children who you think are developing significant ascites, maybe possibly an earlier intervention with carvedilol may be of benefit. Okay, next slide, please, Maria.
I think this was,
okay.
Yep. Can you hear me?
Yeah, I can hear you. I think the slide is still stuck a moment. Yeah, there you go.
Okay, so the thing was, so I work in Hospital Vall in Barcelona, in Spain. Also do 25 liver transplants a year, more or less. And we have like a very different experience with carvedilol than Marumbo was talking now. So basically it was a bit to compare how we were using it in both settings. So this is a study that we published a few years ago, and it was an ambespective observational study with 2 cohorts comparing what we did before through primary prophylaxis and secondary prophylaxis using just endoscopies, or the prospective group of patients when we started to use, retrospective with propranolol and prospective using endoscopies. So it's obviously not a big cohort. There's like 30 patients in each group. The thing is that what we saw is that accumulated probability of bleeding was actually lower in the patients that we scoped than in the patients that we used propranolol. I have to say that even though there weren't differences in demographic, laboratory, or ultrasound data pre-treatment, the propranolol group, actually, you can see that there are much more patients that end up in liver transplant. It's 7 patients in total and just 3 in the prospective group. So it's the possible interpretation of this is that actually the pre-treatment severity of the propranolol group could have been great and partially explaining these differences. And what we actually do now is patients that have portal hypertension signs, low platelets, splenomegaly, we scope them we do primary prophylaxis, scope them, and either do ligation or use carvedilol. Carvedilol we only use in those patients that have gastric varices or portal gastritis. In the rest, we usually just ligate those varices and don't use nor carvedilol or propranolol and follow up. For now, we're just using low platelets and splenomegaly, low platelets being under 150. And we are starting to use spleen stiffness, but not yet in our protocol. Right now, these are the patients that we've had with carvedilol for in the past 10 years. So we've had these 10 patients that half of them, more than half of them, 6 of them were because of portal hypertension. You can see there's a difference in ages. Sorry that the slides don't work because it's everything in one slide. But basically you can see the age varies a lot. The youngest we've started carvedilol is in patient was one year, and the majority of patients are on carvedilol because of secondary prophylaxis, just 3 of them primary. The course for treatment in all of them except 1 is because of portal gastropathy or gastric varices, as I said, using our protocol. One of these patients, patient 6 CPC, actually we started treatment because of continuous bleeding. We couldn't find exactly where he bled. He was a patient that actually underwent a mesocardial shunt, that had a partial thrombosis, kept on bleeding, couldn't find where, started carvedilol and has been fine for the past few years without bleeding again. We actually stopped carvedilol in 4 of these patients after doing other treatments. In the first patient because of a mesorection, and 2 others because of mesocardial shunts, and 1 because after interventional radiology. We usually, in these patients, what we do is scope them 3 months after whatever intervention we've done, and if everything's okay, you can't see portal gastropathy and so on, that's usually the case, we stop carvedilol in these patients. So very different settings of when we use carvedilol than compared with Marumbo, and obviously open to discuss if you'd like to. I'll stop the presentation, and if you have any questions, you can make them through the chat, and if not, we can continue with octreotide and then have the questions at the end.
Someone's already asked Maria about what is our opinion on treatment of cystic fibrosis patients with advanced liver disease, cirrhosis, having portal hypertension with beta blockers. I mean, I will say, I mean, it's interesting enough, depending on what CF care is like where in your region, what I've noticed certainly in the north of England where we are is that we're finding it's much, the last time we transplanted a child from CF because of severe portal hypertension and liver failure was almost 5, 6, 7 years ago. So we're tending not to see such severe portal hypertension in the CF kids, but if they did present in the same category as I mentioned, the older children, I wouldn't be against it, providing that was in line with the supervising respiratory team. I don't know what your thoughts are, Maria.
I think the same for us. It's been also a few years since the last CF we transplanted, more than 5 for sure. And we've seen benefits of the last new treatment that they are using. Yeah, obviously, as you say, if it's in line with the pneumologists, I would think it would be fine with us too. But as I say, it's not a setting that we've used. I mean, we haven't used it in, I mean, on its own. Right? We would use it if they had, you know, gastric varices and so on that we can't ban, because this is our hospital protocol, not just use it to prevent decompensations and so on. But yes, I wouldn't say no just because it's cystic fibrosis. So I think we can continue with the octreotide and then circle back if anyone else wants to ask any questions on this, or if not questions, do the same as we've done, like talk about whatever you use it in, if you're using it, or if not, if you've had any problems with carvedilol, whatever. It will be open to discussion.
Just check the other chat. No, there's nothing else in the.
No, can't see anything. Okay. Back to this then.
Great. Yes, thank you. So I know we've been doing this talk about carvedilol, and I just thought, given that the title of the presentation was therapeutic options, I think we shouldn't forget some of the drugs that haven't failed us and have been trusty, and many people have used for many, many years. They can still help us out very much. And I wanted just to highlight two cases, which, as you'll see, are very, very significant with severe portal hypertension, where we ended up using long-term octreotide for these patients with good results, and with quite interesting cases. So just a quick brief recap. I'm sure you all know octreotide is a synthetic somatostatin receptor agonist. So it's got multiple uses. The indication that we use it obviously in hepatology is to reduce the splanchnic blood flow. And if you look into most people's acute variceal bleeding scenarios in their protocols, you'll find subcut continuous, so intravenous octreotide as part of the treatment. So it's used acutely world over. So I think most people are very comfortable with its usage and use it all the time. But I think I'm not sure how many other people have thought about using a subcutaneous long-acting version depot injection as to control the cases. So we tend to use them in cases where we believe that there's a high risk of bleeding that we're not going to negate by doing multiple endoscopies, and that maybe the child's medical condition stops us from performing multiple endoscopies at a high rate because it's just not good for the child. And clearly, obviously, if this is a child where their comorbidities mean that no IR or surgical intervention is possible or indeed appropriate, so we have to think of some other way to control their varices. We can't give them a TIPS, but we need some method to control their varices and prevent them from getting morbidity from bleeding. Next slide, please, Maria. So the first case is a 13-year-old boy who had global developmental delay. He actually had spastic quadriplegia, was nonverbal, was feeding via gastrostomy tube, and had a seizure disorder in his background. The family had been taking them to the hospital, essentially saying he'd been vomiting over and over again, seemed very uncomfortable, and he had abdominal distension. And unfortunately for them, he went in for a good couple of weeks before he eventually had a full set of bloods done, and an amylase was checked, and it was over 4,000. Now, he was in a district general hospital, so not a teaching hospital. So they were managing him conservatively. And then they called us at the liver center because essentially he had an upper GI bleed. He had frank blood coming from his gastrostomy and melena. They did a limited scan, which they saw a thrombosed portal vein, massive ascites, dilated bile duct, and some early splenic, early perisplenic varices. Next slide, please, Maria. So when he got to us, we took him straight to theater, mostly to get IV access, stick an abdominal acidic drain in, and we performed an upper GI endoscopy. And as you can see from the picture, he had big grade 3 varices, which we banded, and we sent fluid chemistry, which confirmed that he had a high fluid amylase, because by that stage, actually, his amylase had actually come down to almost about 300, but he appeared to be in a lot of pain. But so he had more amylase in his acidic fluid as he did in his serum, and the chemistry and the sort of microbiology of the fluid was completely negative. So we weren't concerned about an infection on top of that. Next slide, please, Maria. We did an MRI scan of his abdomen, and we were shocked to find that he had a large cystic mass in his head of pancreas. which essentially was involved with his entire portal system. So we saw a clot in his main portal vein, his SMV, his splenic vein, and right into his enterohepatic portovenous branches. There was clot everywhere. And even though it's super rare, and I personally have never seen a pancreatic tumor in my career, and I thought I'd come across our first one because, you know, everybody thought this must be tumor. Next slide, please. And actually, we performed an endoscopic ultrasound, really with the idea, with the aim of getting biopsies, which actually, shockingly enough, was completely negative. So we sent cytology in the fluid; it was all negative, and the histopathologist must have checked the sample for us 2 or 3 times, and they were absolutely certain that all we were looking at was just acute changes on the background of severe chronic pancreatitis. Which, when we went through and examined the history with the parents again, they said that nope, he'd been absolutely fine up until the few weeks prior when he presented with his abdominal discomfort. Next slide, please, Maria. So effectively, he was in hospital for about 5 weeks. It was a slow burn in terms of, you know, we started him on PN, then introduced a jejunal tube so we could feed him beyond his stomach. He had been on IV diuretics, which we gradually switched to oral spironolactone, which he eventually stopped at discharge. Because what we did fairly early on in his case, given the extent of his thrombus, we thought, well, we're not going to give him anticoagulation because it's far too much thrombus and too extensive, and it would be too dangerous at the high doses. So we ended up we made the decision to actually go to depot octreotide very early, actually, in his management. And what we found is his ascites came under, as I've mentioned, his ascites came under control within a couple of weeks. Given that he was quite neurologically damaged, we did, just by process, did speak to King's College, which is our local multivisceral transplant unit, just to say what they considered, given that he had thrombosed everything, and they predictably turned him down, but we did that to give the parents all the options. His hereditary pancreatitis screen came back completely negative, so we're really at a loss as to what had triggered this episode of pancreatitis. And certainly he'd been in hospital in and out throughout his life, so there wasn't a case of him getting something exogenously. But so where we are now with this child, it's been about 2 years now, where we follow him up on an annual basis with an ultrasound scan, which demonstrates that, yep, the clot is still there, but his ascites is completely under control. His platelets are very low, but he hasn't had a bleed and we haven't had to scope him. So maybe it's a false dawn, but 2 years without an endoscopy and without a bleed, we're fairly happy with that result from the octreotide. So the next slide is a 6-year-old girl who had consanguineous parents. There were refugees that recently arrived into the UK. Whilst they'd been sort of on their trip, on their refugee trip, they'd been told that their child had cirrhosis, and they were given some ursodeoxycholic acid. The child had developed some seizures, and they were given sodium valproate. So the parents really had no idea what was going on in terms of their child's health. But they arrived in the UK, and they went to their local hospital with a fever, lethargic, and jaundiced, and so they were sent to us for further investigation. So we're doing sort of investigations from the ground up. Next slide, Maria, please. What we found is that her chronic liver disease screen was completely negative. You know, she had a mildly raised IgG, positive anti-SMA, but she was young. We did a liver biopsy anyway, which didn't demonstrate any autoimmune hepatitis. However, it was quite a fibrotic biopsy. Sort of half the biopsy was all fibrous bands. There was absolutely no inflammation, but there was some cholestasis, and there was nothing to point at an obviously metabolic cause either. The child had a large, sort of nodular liver in keeping with cirrhosis on the imaging, and the spleen was large for age. But in actual fact, as you'll see on the next slide, please, Maria, her platelet count actually initially wasn't bad at all. It was 242. So at the time we thought, well, there's portal hypertension, but in our center we'd normally say if children had a platelet count of less than 120 on 2 consecutive occasions, that would prompt us to perform a prophylactic endoscopy. And this child didn't meet that criteria. But the plot thickened in that the parents had mentioned that actually, because she looked delayed to us, and the parent mentioned that up until the age of 3, she was completely normal, and developmentally normal, but she started regressing, losing some of her motor skills and losing some of her verbal skills. So at that stage, we thought, well, there must be something metabolic going on, and we considered to extend our investigations, including skin and muscle biopsies, etc., which all came back, as you can see, negative. The MRI brain was significant, so the word changes there, which made us think that, well, this is clearly something multisystem, and we were convinced this was going to be mitochondrial, but the mitochondrial genetics were completely negative. So we just left her to follow up, and we're just going to keep liaising with our metabolic colleagues in terms of what may come further. This plan obviously got laid to waste because shortly after discharge, she presented with a significant upper GI bleed. As you can see, she had significant varices and sort of contiguous varices into her stomach as well. She was placed onto a regular banding program, but over the next year, she suffered 2 breakthrough bleeds despite the prophylactic endoscopies. Next slide, please. And by that stage, after one of her admissions, it was clear that her neurological status was deteriorating. And we'd asked the neurologist to get involved. They did a baseline EEG, and because they felt that she was getting encephalopathic, but somehow through the EEG, I'm not an electrophysiologist, but they determined that this wasn't because of encephalopathy. Given the severity of her bleeding, under normal circumstances, a child like this would have done a TIPS, but then because we weren't convinced we were going to transplant her, we deferred from doing a TIPS because in our center, a TIPS is a bridge to a liver transplantation. So just like with our previous case, we thought, well, what can we do to prevent her bleeds? And we put her on subcut depot octreotide at the time of one of her endoscopy discharges. Next slide, please. Eventually, her whole genome sequencing returned a diagnosis of atherosclerosis, which I understand is a very rare sort of cholesterol synthesis disorder. And so that sort of justified our decision in terms of not offering her liver transplant. And so she's now firmly under the care of a metabolic surface, trying the various enzymes and medication trials. But from our perspective, yes, she's become more cholestatic, which we suspect is a consequence of just getting more fibrotic, and her platelet count has continued to drop. But again, like her, she's not had any bleeds in about, like the previous case, she's not had any bleeds in about 2 years, and we haven't had to perform another endoscopy. So those are the cases I had to bring up, just to sort of remind people that there are some agents out there that can really help you out in a pinch if you need a result very quickly. Thanks.
So just in contrast, and to start, with the debate on this, in our hospital, we hadn't used depot octreotide in the last 10 years at least. But just last week, we started on one of our patients. He's already 18, still transplanted when he was a kid for biliary atresia 20 years ago, had portal thrombosis and developed portal hypertension after that. And in the last few years, he's had numerous episodes of bleeding, of upper GI bleeding. And he actually needed an urgent mesocable shunt for one of them because we couldn't stop him bleeding. And that got better after that. But then 6 months later, he comes back to our hospital and he's bleeding again. Upper GI bleeding looks like upper GI bleeding, but scoping is completely normal for that he has angiomatosis in all of his intestine. So one of my questions here was, because we haven't found anything or at least published relationship between portal hypertension and these lesions, but we did, as was done with these patients, start him on octreotide because for the acute bleeding, it was actually working intravenously here with somatostatin. So we said, let's try this and starting on depot, and he's been fine for the last 3 weeks after being here for more than a month and needing transfusions every 3 days practically. So yes, think about other agents that it can be a useful tool. I'm not saying that this patient is actually this, because obviously he's older and has these other lesions, but related or not, it's obviously a good tool to think about too. I don't know if anyone here has other experience or uses it or has used it in pediatric patients, but we're happy to discuss it. And also for your Marumbo, when would you use octreotide or carvedilol in these patients?
It's interesting. You mean the ones with telangiectasia? You mean?
No. In yours, in the
any
two
patient.
patients that you started octreotide.
Yeah.
Why not carvedilol?
Well, I
mean,
think we see with both those cases. I think with the extensive thrombus, we felt, given that he presented with a huge and clinically significant bleed, I think at the time we felt that well, I think it's a matter of what our personal feelings are. We felt that maybe in terms of preventing acute bleeding, octreotide is going to be more useful than propranolol, because propranolol wasn't on our carvedilol wasn't on our radar at the time, was it? It was propranolol in those days. So we thought, well, we need something a bit more. What we felt was a bit more effective than propranolol. I think nobody felt.
Change it now, though.
It's interesting you say that, because we've said we haven't done it. We haven't used it for extrahepatic portal vein obstructions.
Yeah.
I think right now I wouldn't be comfortable switching. I don't know if anybody else might convince, but I wouldn't be comfortable switching because we haven't had any problem with it. I wouldn't be comfortable switching at the moment.
And the other thing is that I don't know about what you're using, but what we're using with this kid is intramuscular octreotide that's once a month, and probably it's easier than carvedilol every day.
That's the other aspect, because yes, we're doing subcut, huge depot subcut injections, and that's and the parents appreciate that a lot.
Yeah.
I might the second child, who is obviously clearly cirrhotic, that's a child we might consider switching to carvedilol, because that's more intrinsic liver disease, not so we might consider that if that's easier for them.
There's a question: what would be the approach regarding periodicity of endoscopy? Well, in our hospital, usually what we do is, once you develop clinically significant portal hypertension, we can discuss what that means, as I said, but basically we scope all patients and as surveillance, and if we have to do anything, band anything or start them on carvedilol, we usually then scope 2 to 3 months after that and continue scoping until it's normal. The majority of our patients, after 3 or 4 at the most sessions, you then have it normal and then switch to 1 year endoscopy, one endoscopy a year. If the first one is completely normal and you're stable, then 18 to 24 months. And then if during that time you worsen in any way, we would do it before. I don't know about you, Marumbo.
I think this is where I think the context matters in terms of our approach, because at the moment we're not using it for extrahepatic portal vein obstruction. Okay. So we're still, we may expand it. We're still keeping carvedilol only for listed patients, or patients with, with chronic liver disease. So for example, in our teenagers, so because they are in the UK, we hand them over at 16 years of age. So the typical case is that, an undiagnosed autoimmune that walks in at 14 years of age, they clearly have portal hypertension, but they're nowhere near transplantation. So what we'll do with those kids, they'll get when they're having their biopsy, we'll probably do an endoscopy at the same time. And then, so we'll know what the state of play is, then start them on carvedilol, and then forget about it, because that's what the adult team do. They just start and only scope if they bleed. That's for the teenagers, the older children. For the younger one, if they bleed, they'll scope them if they bleed. But we establish them on carvedilol. But for the younger ones, again, it's such for us, it's listed patients only. So in the early ones, to avoid scoping them in the first place. But and then I said, and just like with the adult team, if they bled, we'd start scoping them. But I think we'd be hard pressed to stop scoping them if they'd bled once.
But do you scope before bleeding?
Yes, for most of our patients we do. So the portal vein obstructions, or you mean the liver disease?
Both.
For both. For portal vein obstructions, we scope them all. So everyone gets scopes and treatments for portal vein obstructions. Yes.
the other question is, can we use carvedilol as early as 6 months of age? Cardiologists do, so we haven't.
Yeah, no, we haven't either. I think we've kept it to 12 months of age.
Yeah, that's true.
Is what we've done, and I think you're in dire straits if you need for our context. I think you're in dire straits if you have liver disease. That's significant in the sense of that you're scared about scopes. So that's a bad situation to be in. You'd be listing that patient anyway, I'm guessing. But we haven't done it under 12 months.
I see them. And sorry, just to go back to what you said, that the adults are doing it. They're actually going through our patients from the past 20 years to see, who had carvedilol and so on. I found like 4 or 5 that it was in the first visit in the adult team, they were started on carvedilol. So maybe, during the transition, we could also change a bit, or, it made us think a bit if we can start using it too. Anyway. Don't know if there's any other questions. Not in the chat. No. Would you like to comment anything else?
No, I mean, just like I said, this is all early, obviously, especially with the carvedilol, it's all early. So I think one of the things that we'll be trying to do as a group, Portal Hypertension special interest groups, to gain consensus. So I think we're in the phase where everyone's starting it. So hopefully in the coming years, we'll have a better sense of the effectiveness of it and which patients would benefit most from it. That's what I would say.
Yeah, probably try and do proper, if we can set up proper studies within children. I think that would be one of our main goals, starting by defining what clinically significant forward for hypertension is in children, and etc. So yes, it's going to be interesting. Thank you very much to everyone attending this webinar. Hopefully it's been of some use. Thank you very much.
Thank you.